So I alluded to sort of early on here that we've seen a lot of advancement later on in the non-muscle invasive disease space. So we've seen really a big focus for maybe 5 years or more in the BCG refractory, unresponsive, pick your terminology, space. So it's been a bit slower coming earlier in the disease space. And so maybe Dr. Daneshmand, you want to give us an overview of the changes we've seen in the BCG unresponsive or pre-treated space, and how that's going to transition forward into the earlier.
Yeah. So it's been, first of all, incredibly exciting to see, all these novel therapeutics and novel delivery mechanisms, from oral to intravesical, more intravesical therapies to now devices being placed in the bladder for drug delivery. So it's nice to see we're thinking outside the box in terms of, we've been doing this for 30 years, but putting solutions in the bladder and trying to think of combinations of things, and systemic therapies too, the addition of systemic therapy. So we're seeing a multitude of trials now looking at the BCG unresponsive space, kind of with very different mechanisms of action than what we're used to. T helper response and the cytokine release and all that, to chemoablative therapies, to sustained delivery of the same medicine we've been used to, like, for instance, the TAR-200 gemcitabine. We're used to all the same methodology for all these patients. 1 hour of the same, of a different drug in the bladder, 6 weeks. It takes 6 weeks. Everything is 6 weeks. So we don't test these out rigorously. So now we're seeing the additional mechanisms coming in, and it's really nice to see that all the work that was done prior in the past 20 years in terms of what molecular targets there are on these cells. We've known these for a long time, but now we have targeted drugs to be able to do this. So again, the overview would be, lots of intravesical treatments, gene therapy, ablative therapies, drug device with eluting chemotherapeutics, systemic therapies with checkpoint inhibitors, adding on to the already therapeutics we have, including BCG. How can we make that better? So we'll see how this pans out, but it's really nice to see the early results are quite good for many of them.
Right. And so, you've alluded to, this is all in the BCG pre-treated space, but that brings us into a sequencing question. So maybe Dr. Agarwal, I'll ask you, to get to these drugs, do you think our patients need to have seen BCG before, or how, to what degree should we be exploring it in patients who've never seen our current standard of care?
We have kind of shot ourselves in the foot by making this definition of BCG unresponsive disease, because we sort of necessitate BCG, and especially during the BCG shortage that a lot of us experienced, we couldn't give these drugs, because even if we wanted to, because we didn't have BCG to put them through first. And I'm in the camp that I think BCG, we just need a drug to induce an immune response. And I don't think it's necessarily something magical about BCG. And so I'm interested in the bridge trial that is going to compare BCG head-to-head with Gemdosi, because I think if we are able to establish that they are comparable treatments, then I think we can go away from BCG, and we might be able to, use other drugs in a frontline setting. But I think right now, the standard of care is, if you have BCG for high-risk disease, you should offer that to your patients. And ideally, there's an old mathematical modeling paper that looks at when to give the BCG, and the magic spot is 2 to 6 weeks afterwards, if you believe this paper. So I try to do a good resection with blue light, try to clean out all the areas of CIS, and then give the BCG within 2 to 6 weeks afterwards. But I would love a world where we don't have to give BCG.
Yeah. Dr. Porten, you see you nodding along. You see it the same way?
Yeah, I think the shortages affected everybody a little differently. And so I think that in the unpredictability was also difficult, meaning you had some, and then all of a sudden you had none, and then you had a lot again. And so that made it, it made trying to use data to classify patients to try to do the best next thing very difficult in terms of sequencing treatment. When BCG goes away, patients are afraid naturally, right? Because this is a drug that we said, or I said, this is what works, this is standard of care. It's really successful in X percentage of people based on your risk group, and it's going to it's going to be awesome, right? And then all of a sudden I'm like, well, actually there's none, right?
We
And
can't give
so-
it to you. It's really great, but we can't give it to you.
And so then it's well, can we do something else? But now it becomes messy. You've had 3 BCGs, now 3 gem. Like what? Now I have this whole set of very mixed group of patients, and now when they have a recurrence, I don't think they fit many groups. And so I agree with you that moving to a world where there's more than one thing in the front line is going to be, I think, key, and I think it will help patients.
Absolutely.
But then I also envision is if these things move into the front line, now our whole definition of BCG refractory is going to go away, right? Now we need new definitions
Exactly.
for these new indications and the sequencing. If we're going to be using Gemdosi first line, it's like EV Pembro. Now EV Pembro's first. Do we go to Gemcis afterwards?
Yes.
I guess. And it's the same thing's going to happen. So we'll use Gemdosi. I guess BCG is a highly effective drug. Look, we're not going to get away from BCG. It's a highly effective medication, and the mechanism is there to stay, right? But we do need other therapies available, and it really is exciting. I think that's up to us as an academic community in the future to see what sequences are the best to work out, redefine what's BCG experience exposed or just treatment exposed in the past, and you're just going to go from one therapy to the other.
We might get into that med-onc world of the goal is just to change your mechanism of action, right? Next line of therapy needs to be a new mechanism of action.
Yeah.
And it doesn't necessarily matter which mechanism you got before. As long as you're switching, maybe we'll get some benefit. But in that BCG treated context, I'm interested in thoughts from all of you. What did you think about the Bond 3 trial presented yesterday by Mark Tyson here at SUO? Maybe I'll start with you, Dr. Daneshmand.
Sure. First, I think I can say the name, Cretostimogene grenetorepvec. So.
Oh, wow.
That's pretty good.
Thank you. So yeah, really exciting data. So we've seen the combination data before, like last year with the Pembro, having very high CR rates in the 85% range, I believe. And now we want to see what the individual components. So Bond 3 is looking at just Credo alone in this BCG unresponsive phase, and we're seeing a 75% CR rate at any time point. We need to see 12-month data. But for a treatment that is very well tolerated, these are very high CR rates, right? And we're used to seeing 20 and 30%, getting used to these 30% numbers. And of course, the FDA's bar is set even lower than that because we're used to Valstar in the past, with less than 10%, 12 months. So really exciting to see it, and especially the tolerability. These are not immune, related toxicities. These are all very low grade. I believe there's no grade 3, 4 toxicities. Most of them are very low grade. So exciting results, and I think we're going to see more. And we really need to see duration of response. It's one thing to see CRs at 3 and 6 months. I really want to see 12 to 18. What's relevant in this patient population to me is that 1 to 2 year. Is this going to last? Because we've seen plenty of these therapies that work well early on, and then there's a tail, there's a drop off. But so far, from everything we've seen, I think this is really exciting.
Yeah, it's interesting. It about 31% of the patients had to be salvaged with the second induction, but still, that's pretty good. That majority got through one induction and then got maintenance and did really well. So, but I think 6 months data was what was presented. It would be great to see 12-month data. There was a slide with the swimmer's plot, and I think some of the patients made it up to 9 months. But you could see there was always a little bit of a drop-off already at 9 months of patients who recurred and came off the trial. And so I'm afraid what we're probably going to see is the 12-month rates will be different and lower, obviously. And so the question is going to be, do you combine it with Pembro? Do you combine it with something else? Do you look at some other installation besides every 6 weeks? Because again, we're just following the BCG paradigm. We have no data to know what's the optimal, number of treatments and the duration the drug is held. I mean, there is a protocol they have, but who knows if that is enough withholding within the bladder to actually get an effect. So.
But I like that second induction. I thought, to design a trial to say, okay, if it didn't work at 3 months, most previous trials would say, okay, we're done, a patient recurred, but let's do a second induction because we do, and we can salvage some of these patients based on the mechanism. So I thought it was very insightful to include that into the trial. And I think when designing future trials, we need to think about that as well. That if the mechanism makes sense, we potentially could do a second induction of whatever we're using.
And also if its tolerability is good, right? Because
exactly.
that will allow you to do second induction,
Right.
thinking about different ways of dosing.
So Dr. Porten, how do you put the data you saw here, Bond 3, in context with maybe 2 or 3 of the other studies we've seen in the last year or two in the same space? So maybe looking at TAR 200, or looking at N803, thinking at adstiladrin.
70 is the new 30, 70%.
Our bladder
That's why
cancer
you're seeing
patients will
everything.
like that, right? Our bladder cancer patients will love it, right?
Exactly.
All of those trials and studies, again, had these rates that we haven't seen before, right? In the 70%. And I know the definition's a little different, or response at any time, or however you cut it, they were higher than what's been sort of seen in the past. I think the next question will be, is that if all of these become available, well, how are we going to sequence these therapies appropriate? It's always better to have more things than less, I think, or more tools in your toolbox than less. But I think that's going to be a really difficult setting or situation to be in. Good for patients, harder for us.
Choice is nice, but it forces you to make choices, right? It's easy when BCG is your choice and everybody just gets BCG as long as it's around, but you've got 4 or 5 choices.
Yeah, but I can imagine, in the future, we'll be getting calls that the community has tried this, in whatever combination they do, and then they come to us and we're like, all right, we got one more trick up the sleeve, we've got this additional either trial or this new medication, or this is what you should be doing. Yeah, it's going to be tough, gathering the data. It's very much like prostate, isn't it? We now have so many combinations of therapeutics in prostate cancer, advanced, early metastatic, and metastatic, that really now the question is sequencing in prostate, or what's your favorite drug of choice? I think delivery and mechanism and installation and a discussion with the patient of what they think. Adstiladrin has the advantage of once every 3 months. So maybe for the patient who lives further away and is only going to come in once every 3 months, that a CR rate at 12 months is acceptable to that patient. You hope for the best. And as long as you don't lose the window of opportunity to cure the patient, then that becomes an acceptable. Other patients are very much engaged. They want to come in every week and they can get an installation. Others don't want a device in their bladder, So maybe, discussions with the patients is going to help us decide as well.
Absolutely. So if we kind of circle back to one of the conversations we had before in terms of, the intermediate risk space and this notion of chemoablation, I'm interested, Dr. Agarwal, your thoughts on the ATLAS study. It was published, I think, a month or 2 ago. Maybe walk us through sort of what happened in the study and what you think of the results.
So this was a trial with the UGN 102 product, which is the reverse polymer device or delivery mechanism with the gel that's basically mitomycin in a form that can stay in the bladder for long periods of time, 6 hours, and then you pee it out. And it was basically a randomized trial between patients. The inclusion criteria were low grade, intermediate risk non-muscle invasive bladder tumors. So tumors that were multifocal and low grade or larger than 3 centimeters, or patients who had low grade tumors who recurred frequently or within a year. And those patients were randomized to upfront TURBT or upfront UGN 102. And at 3 months, they looked at response rate. It was in about the 65% range for both arms. So chemoablation, at least based on that data, it seems that chemoablation is equivalent to an upfront TURBT. Those patients then who recurred at 3 months were salvaged with a TURBT in both arms. And then they looked at recurrence-free survival. And I can't remember the numbers, but the curves separated in the UGN arm, and they stayed separate throughout the follow-up. And again, I can't remember the length of follow-up, but it essentially looked pretty impressive. At least giving this idea that upfront chemoablation with some salvage TURs can lead to better recurrence-free survival.
Okay. And Dr. Porten, what do you think? What clinical information do we need to feel comfortable using chemoablation up front? Like, how are we going to ensure that this is the right patient for this approach?
And I think this is where the key is that the patients were selected based on a biopsy in the clinic, and then you could randomize, and that was what was the representation of the low-grade disease. And I think it gets back to what I think we were talking about a little before, is that there is some heterogeneity. So if you have 20 centimeters of tumor burden in there and you get a little biopsy and it's low grade, do we think that's representative of what's really happening versus decent amount of little low grade tumors, you biopsy it and you're like, these all look kind of low grade. Those are different patients. And so I think a concern of most also urologists will be, am I missing a high grade lesion and under treating it? You do consider doing a TUR if it doesn't ablate away, right? So you're able to find it then. Does that 3 months make a difference? And would that lead to oncologic outcomes that are different? Yeah. So I think some of that still needs to be figured out or sorted out. But again, it's pretty impressive to have a tool, because not every patient can have a TUR, and maybe that TUR may not be so easy. We were just sharing a couple of cases that were challenging as kind of some examples in that situation. I would say that would be a good.
It's hard to test, isn't it, in a prospective trial, because you're talking about envisioning, okay, you're biopsying this tumor, you've got mostly low grade, you're worried about high grade, but then you're putting this mitomycin gel in there. Who's to say it doesn't work in a little bit of high grade, you know?
I don't know.
We've been using it in high grade. We've been using mitomycin in high grade disease for a long time. So, you know, if those are included in there, maybe this efficacy that we're seeing actually includes some patients with a little bit of missed high grade, and it's okay. These are small tumors. They're not super high risk. So, I don't know whether we need to do a full TUR to assess for that. But you're right. I think the size and kind of visual inspection kind of lets you know the risk status of these patients. But again, it's good to have options. Yeah.
Good to have options. So, Dr. Agarwal, we saw updated data on this treatment approach here at SUO, the Envision study. Maybe compare and contrast Atlas and Envision. What did we learn that's new out of the Envision data?
Yeah, so the Envision data was basically a single-arm trial, again, of patients with intermediate risk bladder cancer who met one of those three definitions that we went over, and they were given UGN with I believe it was six installations, and then looked at 3 months. And at 3 months, the complete response rate, I believe, was 79%, and really well tolerated, low toxicity. And unfortunately, that's all the data that was really presented. So we don't know much more but this was a group that it's interesting to me that the response rate's a little bit higher than what was seen with the Atlas study, when it seems like the patient groups were very similar. So I'm not sure whether they were selected better. Maybe they had smaller volume disease, and maybe there is like a sort of a magic Goldilocks type of amount of tumor burden that would be really amenable to chemoablation. So but you know, that result, 79%, is pretty impressive with just chemoablation. And I think, like the Bond study, we're going to want to see 6 and 12-month data to see how durable it is.
Dr. Porten, what do you think about how your patients will approach this? Do you think having an option that doesn't require going to the OR is going to be very appealing? Like, how much utilization do you think this treatment approach is going to see?
You know, I think so. I feel like Envision represents that situation that we were talking about a little earlier. Those patients who we know is low grade, and you're just looking for strategies. Do you do surveillance?
Sure.
Do you ablate every now and then in the office, or do you do adjuvant, or traditional adjuvant intravesical chemo? And now there's like, okay, well, maybe I don't full grade or do that in the office, and we use the reverse thermal mitogel instead, right? Do we do that? I think it just adds another option in managing patients in this way, and you can sort of talk to patients about that, right? Okay, so what is the most distressing part of this whole process for you? For some patients, it's the anesthesia and the TRBT. For others, it's the cystoscopy itself, like the anticipation, everything that leads up to that, like living 3 months at a time type of a thing. For others, as long as it's not bleeding, I'm doing my thing, it's not growing, I'm fine. You can keep monitoring it, right? So I think that this is just something that you have to work into the patient discussion. I think patients would be thrilled at having like another tool or option. The only caveat to that is in particular that long-term data. So if this can or shows that durability of that response is going to give you a really long-term sort of settling of your recurrences, I think that would be big and would change things.
Yeah. One other point, I think, we keep talking about CR rates, and in particular, intermediate risk disease. You talked earlier about, what's more important, recurrence or progression. In some patients who are elderly on anticoagulation, perhaps we just want to maintain and prevent progression. If you got 20 high-grade TA tumors, for instance, we're currently doing intravesical treatment if it's really prohibitive to take them to the OR. So I can actually envision, if this becomes one of our treatment options, that we would be doing chemoablation with this method and just keep looking in there and making sure they're not progressing with additional tumors. We don't have to necessarily achieve a CR rate. This is not progressive cancer. Of course, we'll be doing imaging and things like that. Just putting it out there that, we're, for these trials, we're looking at CR, which is, of course, the benchmark you want to hit with these trials. But later, as we have these prohibitive situations, use these tools to prevent the progression of disease.
So there can be clinical benefits that don't necessarily get all the way to reaching a CR, I guess.
Exactly, yeah.
Maybe one of those things. So which kind of patients are you going to be approaching with this treatment approach, assuming it comes to market?
Yeah, so there's going to be lots of potential other options, lots of other trials in place. There are patients, you look in there are 20 satellite lesions. And like, where's this coming from? Of course, you got to look at the upper tract to make sure it's not coming there from there. But I think those patients where I want a ablative type of treatment, I think that would be the most ideal patient who have multiple recurrences at rapid intervals. It makes everyone nervous when you just took them for TOR and then to get 7, 8, 10 lesions, especially with blue light, like you mentioned. You suddenly see all these lesions, and patients are looking at it. This is flexible blue light in the office, and I'm going, "What's that? What's that? What's that?" It's really disheartening to see it. So I think, to me, that would be sort of one of the ideal scenarios for chemoablative therapy.